Hello everyone, my name is Sonu Pathak and I am final year student of Optometry, Southwestern University. Today I am going to report my case which is present in my extensive center. The topic is lateral optometric management of lateral rectus palsy secondary to the diabetic. Here we will discuss about the patient case report with the introduction to conclusion. Recording start हो गया. Introduction. Lateral rectus palsy is also known as sixth nerve palsy or abducens nerve palsy. It is caused by many reasons: poor blood supply to sixth nerve caused by combination of factors such as high blood pressure, diabetic, high cholesterol and smoking. Interruption of the blood supply to one of the cranial nerves causes it not to work. Typical feature of the lateral rectus palsy includes sudden onset of horizontal double vision. The most important issue in diagnosing a microvascular cranial nerve palsy is whether it fits an expected pattern and whether it is isolated. Patient case report. A 50-year male visited to the eye center with the chief complaint of double vision. He was diagnosed with diabetic mellitus 3 years back and is under medication for the diabetes. The complete case is provided below. Patient case data. The visual acuity for the distance was 20/20 minus 2 OD and OS 20/20 and the near J2, and the autoreflection shows plus 50 combined with minus 75 at 63 degree OD and OS is plus 50 combined with minus 50 at axis 104. Anterior segment cornea clear and deep quiet lenses for OD and OS cornea clear and anterior chamber is deep. The posterior segment in OD the retinal hemorrhage noted and the OS the CD ratio is 0.3. And the remark is in OD there is a diabetic retinopathy and OS lateral rectus palsy. The patient was prescribed with 2.5 base up in right eye and 5 base out ground in and 6 base out Fresnel prism in left eye for the control of deviation. Here is a picture of the ground in prism. Discussion. The patient was diagnosed with diabetic retinopathy and was graded as non-proliferative diabetic retinopathy in both eyes. Similarly, the patient was diagnosed with lateral rectus palsy in left eye secondary to diabetes. The patient was prescribed with the 2.5 base up in right eye and 5 base out ground in and 6 base out Fresnel prism in left eye for control the deviation. The patient was comfortable with the prism and the patient was also advised for the saccadic exercise for straightening the muscle. The saccadic exercise, patient was advised to fix his eyes on one target and suddenly move his eyes from the other. The conclusion. Diabetic retinopathy is one of the most common complications of diabetic mellitus and is a major contributor for the visual impairments. Since the possibility of muscle paralysis in the eye are always higher in people with diabetic mellitus, the patient must be made aware of the importance of proper control of blood sugar level to minimize the complication.